I can't read long right. Somewhere around 251, 257, and 258. So this is the most common bacterial infection in pregnancy. UTIs are your most common. And that's, remember, our bladder capacity and our retention. The bladder's a muscle. If all the muscles are relaxed, you have a floppy bladder, and it may not release all the urine and different things, or it may leak urine. So you have all these problems with pregnancy, right? These alterations. So UTIs are common.
It's 257.
257 to 258, thank you. UTIs are ascending, so it's important to detect and treat the lower, your cystitis, to avoid the upper, which would be like your pyelitis or your pyelonephritis. You don't want it to get into the kidneys. You want to treat it while it's lower. We got to diagnose them early because those too can cause preterm labor. If they get pyelonephritis, which is more involved, they're going to need a hospital admit and treat aggressively with IV antibiotics. If we don't treat it, it can lead to septic shock, respiratory distress, preterm labor, and fetal death. If we diagnose with the UA with cultural sensitivity, our assessment, we're looking for dysuria, urgency, frequency, hematuria, low-grade fever. Do they have pain? Of course, we're going to educate them for prevention. Drink lots of fluids, like front to back, empty your bladder frequently, good peritoneal hygiene. If they need antibiotics, we're going to reinforce, be sure and take all your antibiotics. Don't stop after you're feeling better. Increase your fluids. Report any other signs and symptoms that we have. So we're going to teach them. Now we're going to evaluate whether the antibiotics and stuff work. So we'll probably do another UA after all the antibiotics are done to make sure that we got rid of the bacteria. All right. Remember, in pregnancy, the pregnant heart, it's elevated upward and to the left and rotated forward. So it's going to appear larger on a chest x-ray.
Mrs. Chester, if you're talking, we can't hear you.
I apologize. Did you not hear me about UTI?
Yeah, we didn't get any of that UTI or nursing care management.
Okay, let me go back over that. I'm sorry, my mic was muted. Oops. Okay, so quickly back about UTI. Most common bacterial infection in pregnancy. Our decreased bladder capacity and retention are common. Bladder's a muscle. Remember, UTIs can ascend, so we want to treat them early before it gets into the kidneys and the upper urinary system, which can cause pyelonephritis, which needs hospital admit and treated aggressively with your IV antibiotics. If we don't treat it, can lead to septic shock, respiratory distress, and preterm labor. So then your assessment, of course, your dysuria, urgency, frequency, all those signs and symptoms of UTI. Pain. We're going to educate them on how to prevent UTIs, good peritoneal hygiene, reinforce instructions for your antibiotics, take all your antibiotics till they're done, increase your fluid intake, and then we're going to reevaluate them to see if our antibiotics work. So we'll recheck the UA. Sorry about that, guys. That was basically it. Okay. I've got page 1031.
Is the lecture capture going?
Yes, ma'am, it's flashing.
Okay, thank you.
You're welcome. So cardiac hypertrophy and increased blood volume. We know that we've got an increased blood volume during pregnancy. Elevated upward to the left. Here's larger on a chest x-ray. So So your cardiac hypertrophy results from increased blood volume and increased cardiac output. Cardiac output increases and peaks around the 20th to 24th week of gestation at about 30 to 50% above pre-pregnancy levels. Of course, with your increased vascular volume and cardiac output, your vasodilation reduces blood pressure in the mid-trimesters. The woman's pulse rate frequently increases from up to 10 to 15 beats per minute to facilitate effective circulation of the increased blood volume. There's increased risk of varicose veins and hemorrhoids. Remember to encourage our patients to lie on the left side of the feet higher than the heart for at least about 15 to 20 minutes per day to promote good venous return. I hear somebody talking and laughing.
It's still water, Candace. Can you slow down a little bit?
Yes, I can. I was just talking about that earlier. Okay, page 105, pulmonary changes. A number of changes occur to meet the woman's increased oxygen requirement during pregnancy. So you got an increased tidal volume and vital capacity. Remember, the tidal volume, or the amount of air breathed in each minute, increases by 30 to 40%. And remember, changes are related to the elevated levels of the estrogen, the hypertrophy and the hyperplasia. And the progesterone decreases your airway resistance by relaxation of the smooth muscle. So you got more hyperplasia than relaxation of the muscle. And then we talked about enlarging uterus, creating an upward pressure that elevates the diaphragm and increases that subcostal angle. Makes it harder to breathe. Their chest circumference may increase by as much as 2 to 4 inches. And remember that dyspnea is normal. When we talk about fetal oxygenation, so placental function includes the exchange of oxygen, nutrients, waste, and antibody transfer. So your umbilical cord has how many arteries?
2.
And how many veins?
1.
2 arteries and 1 vein. Page 94 is fetal circulation, but you don't need to go into too in depth on that. But 2 arteries and 1 vein in your umbilical cord. Page 104 is your vena cava syndrome or supine hypotensive syndrome. This is a faintness related to bradycardia from lying flat on your back, causing the enlarged uterus to compress the inferior vena cava. So a decreased blood return to the right heart leads to failing or falling cardiac output. So decreased blood flow to the right side of the heart, falling cardiac output causing decreased blood pressure and decreased blood flow to the organs. So it looks like shock. What's 3 things that look like shock?
Hypertension.
Increased respiratory rate. Increased heart rate. What do you, when you're looking, what are you going to see?
No. Cyanotic.
Pallor. What I have here is dizziness, diaphoresis, and pallor. Remember, they get really flushed and sweaty, you know, and so like their blood pressure drops, and so dizziness, diaphoresis, and pallor are 3 things that occur with shock. So just a little bit about congenital heart defects. 242 to 249. The most common heart problems seen in pregnancy. Successful treatment of congenital heart disease has created a new population of clinically complex patients who are now able to reach childbearing age. You know, technology and advances in medicine, people are living longer with heart problems. There's an increasing trend towards pregnancy in older women. You know, we're waiting have babies who are susceptible to heart disease acquired in adulthood. Also, your immigration from underdeveloped nations has reacquainted our Western medicine with a cohort of younger childbearing patients who have rheumatic heart disease. So women with defects have had them fixed and are living longer. There's a high risk of having a baby with the same defect as the mother. The mitral valve prolapse. So the edges of the mitral valve flop back into the left atrium when the left ventricle contracts. Allow some blood flow backward. Most of your patients are asymptomatic. They have odd chest pain or palpitations, and they usually tolerate pregnancy fine. You might be able to hear that little murmur. These women usually do fine. Page 246 just has a little bit about your New York Heart Association classification. So class 1 is asymptomatic. So vaginal delivery will be fine. You can use regional blocks, forceps, whatever. 2, they might be symptomatic with heavy exercise. They would love to have epidurals, no pushing for long periods, anything that's going to strain the heart. 3, they're symptomatic with light exercise, bed rest most of the day. The primary care provider may choose a C-section for delivery. And 4 is bad, they're symptomatic at rest, and 50% of these patients die. So remember, pregnancy puts a big strain on your heart, your lungs, everything. Increased blood flow. A lot of things going on. Page 251, iron deficiency anemia. So it's the most common nutritional disorder in pregnancy. True iron deficiency anemia occurs when the hemoglobin level drops below 10. And then the blood's decreased oxygen carrying capacity causes a reduction in O2 transport to the developing fetus. And this has been associated with intrauterine growth restriction and preterm birth. Your etiology can include poor intake, they're not eating enough iron, they have a malabsorption issue, they have increased body need, or mainly milk diet. They need more iron in their second half of pregnancy, so they need to increase their iron intake. Storages run out by 6 months, 2 to 3 months if a preemie or multiple gestation. So if the baby's not getting enough groceries, especially your iron and things like that, they're going to have that growth restriction. That's why we do fundal height measurements, and we monitor them frequently to see if the fetus is growing and developing the way it should be at each week of gestation. What are some things you think you could see in anemia assessment? Of course, they're easily fatigued. What other symptoms might they have? If you're low in iron, how are you going to feel? Terrible.
Did you say irritable?
Terrible.
Irritable.
Dizzy?
Lethargic maybe? Think you'll have a headache or, could be headache, shortness of breath. Some women who are anemic have shortness of breath, pallor, lethargy, headache, and they may have pica. Because what's pica? It's usually attributed to some sort of deficiency in their diet, right? Some sort of vitamin deficiency. So if they're eating weird things like clay or starch or whatever, what was it, My Weird Addiction, where they eat weird things?
Nail polish.
Nail polish.
But one hates blood.
Interesting.
The pronoun Christians. Whatever this is.
So remember, to have a true anemia, we're gonna be looking at that hemoglobin level, and we're gonna be looking at their signs and symptoms. Are they symptomatic? Even if their hemoglobin is low, are they symptomatic or are they doing fine? So we're gonna assess their energy level, we're gonna encourage frequent rest, increase the water intake, of course, increase dietary iron and protein. Check their vital signs before and after activities, minimize excess demands. We're gonna block our care. If they're in the hospital, we're gonna block our care. We're not gonna interrupt them every little bit. We're gonna try to do more things at once where we get it done and leave them alone to rest. We're gonna try to prevent anxiety. They may need oxygen, because that's carrying the oxygen, right? So they may need oxygen. And remember, you have 2 patients. The baby needs oxygen too, so. May need a transfusion of factor red blood cells. We're going to teach a diet and pharmacology. Iron supplements is probably something they're going to need, such as ferrous sulfate. And then when we take iron, what happens? We get
Constipation.
constipated. So then from taking iron, we're going to need collates and increase fluid intake. So we got to teach them, hey, this is going to make you constipated. You might want to take collates and increase your water intake. There it is, ferrous sulfate. And then remember, vitamin C helps with the absorption of iron. Women should not drink tea because it has tannic acid that interferes with the absorption of iron. Also, milk interferes with the absorption of iron, so they should not take it with milk. They won't know these things, you need to tell them. And they may even need parenteral iron and ferron. We need to include when we're teaching, take this iron, don't take it with milk, don't take it, they'll drink tea. They don't know these things. We've got to teach them. Otherwise, that iron's not going to do them any good. They can be taking the pill, but if they're taking it with something that interferes with the absorption, they might as well not even be taking it, right? Sickle cell anemia. This is page 252. Many pregnancies complicated by this autosomal recessive genetic disorder are associated with poor perinatal outcomes. The gene for the production is inherited from both parents. This causes erythrocytes to become shaped like a sickle or crest under certain conditions, so that a decrease in, such as a decrease in O2 or dehydration can worsen the process. Okay, so when they get dehydrated or stressed out, this gets worse, right? Severe anemia and vaso-occlusive crises may occur during pregnancy, and these problems are associated with an increased maternal and perinatal morbidity and mortality. The respiratory and urinary tracts are the most common sites for your infection, and all infections must be promptly treated because fever, dehydration, and acidosis is going to result in further sickling and further worsening of the crisis. So your treatments, IV fluids, O2, and pain management. These people have a lot of pain from this. And you have to promptly treat them with IV fluids, O2, and pain management. Could cause placental infarctions, those cells be in weird shape that can cause an infarction. So your sickle cell crisis occurs when vascular occlusion and tissue hypoxia occur quickly and widespread. Can cause fetal intrauterine growth restriction, spontaneous abortion or miscarriage, prematurity, and death. So when we talk about abortions, so page 200 to 205. It's termination before the age of viability. So early would be before 16 weeks. Late would be 16 to 20 weeks. Half of them end in the first trimester. We're talking like a spontaneous miscarriage or abortion. Almost half end in the first trimester. 50% of the losses are usually due to some sort of a chromosomal anomaly. Higher needs care is a must. We gotta treat their psychosocial. We have to support these people. So we allow the client and family to express grief and talk freely. We allow them to take as much time with the fetus as possible. You know, when you plan to have a baby, you're gonna have that baby, you're gonna take it home with you. Well, these people don't get to take that baby home with them. So if they wanna hold it, spend time with it, we allow them to take as much time as they need to do that. This is one of the saddest things we'll ever be a part of, and we saw this yesterday. So, yeah, we saw this firsthand yesterday, so very sad. Usually as a student, you really probably shouldn't go in the room. These patients are going through enough, right? They don't need that extra people in the room. But, you know, there is the opportunity after the delivery of the fetus, they do take it to a certain area in the nursery or wherever, and you can go look at that fetus if that is something that you want to do. You can go look at that just to get an idea of what like an 18-week fetus looks like, or a 20-week fetus, and then you will understand why that's not viable. It's not compatible with life outside the womb. If you can't look at it, that's fine. You know, it's not something everybody can do. But as students, we need to be interested in learning for learning's sake. So, you know, if you get a chance to look at something like that and it doesn't bother you, I would recommend you do it. Because you can see the little fingers are formed, the toes, you know, everything. So, it's sad, but it's something interesting to look at. So. So medical management, we're going to check our fetal and maternal well-being for threatened abortions. If it's threatened, they're probably going to be on bed rest, maybe with some sedation, definitely nothing in the vagina. They're going to need IV fluids, they may need blood. If they're Rh negative, they're going to need RhoGAM. Just like a normal pregnancy, they're going to need RhoGAM. We'll monitor the fetal heart tones if they're far enough along. We'll monitor that. But like I said, usually these are early in pregnancy. So our fetal demise pharmacology. If there is a fetal demise, they may want to go ahead and induce to get the fetus out. If the fetus is deceased, then steps are taken to facilitate the delivery. Laminara is a sterile dried seaweed. Misoprostol, methotrexate, and dinoprostone. So you got your Cytotec, methotrexate, and your Cervidil. That's your generic names on the slide, because that's what we use. So your Cytotec does what? It ripens the cervix, right? So they may need to open the cervix. Even though this fetus may be small, the cervix still needs to be open to some extent for it to be able to come through. So they will use cytotech on the cervix to get it ready and get it open so that the fetus can pass through. Methotrexate, that is used, it's a rheumatoid arthritis medication, but it's a type of a chemo drug that can also cause you to have a miscarriage or be used to expel the fetus. So our nursing care, what are we going to be watching for with our vital signs? Our signs of what? Shock, maybe? Because they can bleed out, right? Still a pregnancy and everything, they can bleed out. These clients can hemorrhage easily. So we're going to do pad counts. We're going to save any tissue and clots that we get, because that could be part of the fetus. And we may need that examined, and may need to send that to pathology to see why did this happen. So that they would know for like future pregnancies, if there was something specific going on there, can we prevent it the next time? So as I said, these clients can hemorrhage easily. You have to monitor the contents that are expelled, save all tissue and clots, focus on higher needs such as psychosocial. They may need pre and post-op care.
I think somebody said they had a question.
Somebody have a question?
I did, sorry. Can you hear me?
Yes.
Okay, so my question is it at 20 weeks, if they deliver it 20 weeks, what point would you consider it a spontaneous abortion or an actual delivery that didn't end in a viable, does that make sense?
Yeah, it's going to depend on how far along they are. The status of the fetus. If they had fetal heart tones and then all of a sudden they don't have fetal heart tones, we know our fetus is already deceased, of course. And we did see an 18-week, which we know was no way viable. 20-week, there's no way. There's a difference between a spontaneous miscarriage and a preterm delivery. So, your preterm delivery, your baby's you're going to have fetal heart tones, and you're going to say, okay, 23, 24 weeks, we can probably, with a higher level of neonatal care, save this infant. But it depends on the situation, Do we have fetal heart tones? Do we have a lot of bleeding? What's going on? Age of viability, I'd say 23 weeks, 24. That's pushing it. That's where you're going to maybe see some cerebral palsy, some anoxic brain problems where they haven't gotten oxygen. It just depends on a lot of different things. So right now we're just talking about, we know they're not viable, they're deceased, there's been an intrauterine fetal death. How do we take care of that? So pre and post-op, they may need to do a DNC. They may need to go in there and remove tissue. Because remember we said if the placenta doesn't deliver intact, it leaves any kind of tissue in there, the uterus is going to say, this needs to go. It can't be here. And it's just going to keep sloughing and bleeding. So they may need to do a DNC. So then we'll need to take care of them post-operatively, control pain, focus on their higher needs, as I said, such as the psychosocial. This is a tough time for people. Gestational hypertension. So it's blood pressure higher or equal to 140 over 90. This is page 215 to 220. So we're not talking about chronic. You're talking about chronic hypertension, they're probably going to have it already, and prior to 20 weeks, they're going to have hypertension. We're talking about gestational. Onset after 20 weeks. So 140 over 90, or systolic 30 above their baseline, or 15 above their baseline. That's good to know what their normal blood pressures are, right? That's why we monitor that. Throughout their pregnancy, we monitor their blood pressure. Hypertensive disorders are the most common medical complication of pregnancy. Page 216, 10-1, lists your classification of hypertension. So the incidence of hypertensive disorders is between 5 and 10%, and this complication is the second leading cause of maternal death in the U.S. Embolytic events are the leading cause. Can lead to cerebral hemorrhage, DIC, which is disseminated intravascular coagulation, which we'll talk about, liver failure, renal failure, pulmonary edema, ARDS, aspiration pneumonia, and abruptio placenta. You know, if the blood pressure is high enough, it can rupture our placenta. To diagnose it, the blood pressure is elevated on 2 occasions or more. 2 occasions more than 6 hours apart. We use the same technique, same body position, same arm, same cuff. So these clients are going to be closely monitored with a non-stress test, probably weekly, starting around 32 to 34 weeks. They will not meet criteria before that time for a non-stress test, because you can't monitor the fetus as well before that time. Can't keep it on there to do the non-stress test, so. Preeclampsia. Hypertension can progress to preeclampsia. So you've got spasm as your acronym. Significant change in blood pressure, proteinuria, arterioles affected, resulting in edema. S, significant lab changes, so increase in your liver enzymes and dropping of platelets is going to signal worsening condition. Your M is for multiple organ systems, cardiac, hematologic, hepatic, renal, CNS. The only known cure is birth of the fetus and delivery of the placenta. Signs of worsening condition can also lead to HELLP syndrome. HELLP. This is page 228. So HELLP syndrome. You've got your H is hemolysis, E is elevated, L liver enzymes, L low platelets, P. Serious complication of severe preeclampsia. So you've got a rapidly deteriorating liver function. Most severe case can cause liver rupture. Fresh frozen plasma is often a treatment. Your circulating red blood cells are destroyed as they try to navigate through the constricted vessels. Vasospasms decrease blood flow to the liver, resulting in tissue ischemia and hemorrhagic necrosis. Causing an elevated enzyme level, so your liver enzymes are elevated as a response to openings develop in the vessels and platelets aggregate to repair the openings. You've got all these things going on. The liver's affected. Remember, your clotting factors and stuff is in your liver. So if you've got something that's stressing your liver, so results in tissue ischemia and hemorrhagic necrosis, causing the elevated enzyme level. As a response, openings develop in the vessels, and the platelets aggregate to repair the openings and cause a decrease in platelets available because they're busy doing that job. So there's not as many available in your circulation. And this can still occur postpartum, not just during pregnancy. Sometimes hypertension can even be absent with HELLP syndrome. What you're looking at is your elevated liver enzymes and low platelets, okay? Delivery is a must. And they may need fresh frozen plasma and or platelets. This is bad. Under eclampsia, seizures is kind of what eclampsia is, seizures. So women developing eclampsia exhibit a wide spectrum of signs and symptoms. They could range from extremely high blood pressure, 4+ proteinuria, generalized edema, the patellar reflexes may be 4+, or they could have minimal blood pressure. No proteinuria or edema. And they can have normal reflexes. Their signs and symptoms are the same as preeclampsia, but worse. You can have grand mal seizures. Pulmonary edema is usually present. Hypertensive crisis, coma. These patients are going to need magnesium sulfate, an IV drip of magnesium sulfate, bed rest, and immediate delivery of infant. So your mom's at risk for CVA, CHF, DIC, and abruption. 15% of moms died. So if we think about our patients being on magnesium sulfate, what is magnesium? What does it do?
Relaxes.
It's calming, right? It relaxes everything. So what's that going to do to your respiratory rate? Increase it. The patients are going to be very calm, lethargic. They can have decreased respirations. They're going to be bed rest. They're going to have a Foley. We're going to be monitoring their output. So since magnesium is calming, too much of it can cause a decrease in LOC and a decrease in respiration. So we have to monitor these patients very closely, because they can get what's called magnesium toxicity. It can get toxic in their system. So if some of these respirations are below the normal and are very lethargic, we're probably going to want to turn that mag off. And then there's something that's an antidote for magnesium toxicity, and that's calcium gluconate. So if you've got a patient on magnesium, you might want to have some calcium gluconate handy. And you probably want to turn your mag off and have that calcium gluconate ready available.
Is that calcium gluconate is on drip or like an IV push?
It's like an IV push medication, yeah. You want to have it ready. It's a serious situation. So DIC, that's disseminated intravascular coagulation. That's page 213. So it's pathological clotting that is diffuse and it consumes large amounts of clotting factors, so in turn causes widespread internal or external bleeding. This is a cascade of things going on. So most often occurs in pregnancies complicated by preeclampsia, abruption, or fetal demise. People can go into DIC, or fetal demise. So we monitor for bleeding. We're looking at IV sites. We're looking for petechiae, anything that signifies bleeding. Vaginal bleeding, bruising. We're going to have mom bleeding precautions. And replacement of fibrinogen and platelets. So we're going to have vital signs and very continuous close fetal monitoring. Keep patient side-lying tilt to increase blood flow to the uterus, O2, and then may need blood products. So early diagnosis and prompt management are critical. Preterm labor, that's chapter 16, 437 to 448. And like I said, if I cut off, I'm going to keep recording here. So your risk factors are in box 16-1, page 438. So it's cervical changes and or contractions between 20 and 37 weeks. Women experiencing preterm labor may complain of backache, pelvic aching, menstrual-like cramps, increased vaginal discharge, pelvic pressure, maybe just urinary frequency, and intestinal cramping with or without diarrhea. A diagnosis of preterm labor can be made at gestation 20 to 37 weeks. 36, whatever, close enough, right? So, persistent uterine contractions of 4 in 20 minutes or 8 in an hour. So persistent uterine contractions of 4 in 20 minutes or 8 in an hour with documented cervical effacement 80% or greater, and cervical dilation of more than 1 centimeter or any change in dilation. Some women can go to the doctor and they're already dilated to 1 or 2. As long as they don't make a change. So we're going to rehydrate if it's related to dehydration, because remember, dehydration can cause preterm labor. We want to delay the delivery until the fetus has a better chance of survival outside of the womb, right? The womb is the best place for them. So then we may do what's
Mrs.
called...
Chester?
Yes?
All right, I just have one question before we're cut off. We do have study session right after this, correct?
And the meeting should be extended for 30 minutes. And I was coming in to remind you.
Okay.
So
Okay, thanks.
So our tocilizis is use of medication to inhibit uterine contractions. Some of our tocolytics include magnesium sulfate, that also is calming, remember, so it's going to slow down preterm labor. Nifedipine or Procardia. Terbutaline is another one. So terbutaline is most frequently used in conjunction with corticosteroids to accelerate fetal lung maturity. So they'll also, we want to slow down the labor, but we're also maybe going to give some steroids to mature the fetal lungs, because we know we're going to have to deliver, but we want to make sure maybe those lungs are a little bit more developed. Table 16-1, page 443 has some of your drugs. So terbutaline side effect is widening pulse pressure. That's a side effect of using terbutaline, the widening pulse pressure. So there's a black box warning against the use of terbutaline longer than 48 to 72 hours due to the side effect of maternal and fetal tachycardia. They don't want to use it long term. So tocolytics and steroids, got to keep the butt in the oven for as long as we can. And what happens if it comes out too soon? Throw it in the middle, right? Long time ago. Think of it like bread. Take it out too soon, throw it in the middle. Complete bed rest. Foley catheter, so we're not going to get to go back in. Left lateral position as much as possible. Treat any infections that could be the cause. Super close monitoring. Of course, decrease our stress and our stimuli. And your nurses start to get a little more excited when your gestational age is low. Start running around like chickens with their head cut off, trying to get everything done. So educate our clients. Signs and symptoms, what to report. That's pretty much it. There's a little match game, I think, on one of your slides. That was one of my in-class assignments when we did that. That's a good study session.